director of the School of Geography and Earth Sciences here at McMaster. He's also a professor in the same department there. And he's a former director of the McMaster Institute of Environment and Health. He received his PhD in geography from McMaster in 1994 and worked at the University of Illinois at Urbana-Champaign between 94 and 2000 before returning to McMaster. McMaster always brings people back, don't they? He's held visiting professor positions at the University of Glasgow and California, San Diego. He's trained as a demographer. His research interests focus on population issues as they apply to immigration, migration, health, and aging. So, I'll turn the floor over to you.
Thank you very much, and good afternoon, everybody. It's a pleasure to be here. So I want to speak to this idea of immigration, health, the immigrant effect, and disability. And what I'll be talking about this afternoon is sort of a mix of two different research agendas that I have. The one around immigrant and the healthy immigrant effect. That is one that I've been working on over the past few years, and then disability is sort of a new foray into immigration and immigrant health type of issues. So some of it is very new and just sort of very preliminary in terms of these ideas. So just in terms of the general outline here, I want to take you through, just sort of a very high level. Well, why do we need to worry about immigrant health and immigration here? What is this idea of the healthy immigrant effect that I've already referenced in my title here? So some definitions and concepts, and then some evidence that we've worked on here in Canada, and then move that or transition into disability within the immigrant population before wrapping up with a few conclusions. Okay, so just overall here, two purposes of today's presentation. One, to understand what this idea of the healthy immigrant effect is, and then second, to take a look at prevalence, type, severity of disability within the immigrant population, and comparisons back to the non-immigrant population as well. Okay, well, first of all, why should we bother studying immigration and immigration health? If you're familiar with Canadian immigration policy, Canada receives approximately 250,000 immigrants per year. And over the next few years, our Statistics Canada projects that immigration will be the primary source for the growth of Canada's population and the growth of Canada's labor force in the very near future. So if we want to see Canada continue to grow, immigration is going to be the route. And more than likely, we'll see increased numbers of immigrants. Many of those people come in under economic class. So it's in excess of 60% of new arrivals are coming in as business investors, or they have some sort of skill and occupation that is required within the Canadian economy. Approximately 10% come in as refugees or asylees, so people who claim refugee status within the country, and then the balance are coming in as family reunification members. Oftentimes, that family reunification class tends to be skewed towards some of the older age groups there, because they're coming in, it's maybe their children who had immigrated into Canada as adults, and then they're sponsoring their parents into the country. So we're seeing that arrival of some older immigrants coming into the country at that time. So, right away, when we have immigrants coming into the country, we have the potential for the intersection with public health via that immigrant health status. So for the most part, Canada's immigration laws screens out immigrants who would pose a threat or burden to the Canadian taxpayer and the Canadian healthcare system. Refugees, slightly different or different situation there, and that as long as it's not posed, they do not pose a public health threat to Canadian health, then they're allowed entry into the country. I think some of the deeper or bigger questions that we've seen appear within the literature and the discussion focus on, okay, well, what are the demands that immigrants and these new arrivals place on the healthcare system? And their ongoing health needs. So, what is their demand for healthcare like? Is it greater than the average Canadian? Is it less than, or is it approximately the same? And there's sort of a range of evidence there, and I'll be speaking to that as we go through here. What type of care, or what sort of mixture of care associated with new arrivals? Western versus traditional, for example, or what is the role of family as caregivers, in comparison to what we sort of typically see within Canada, and how much or how does that differ from the native-born population? So, we can talk about this idea that immigrants move from one health set or one set of health risks, behaviors, and constraints to an environment that is potentially very different, includes a very different mix of factors that impact on their health, and potentially adverse impacts. And again, I'll speak to some of these ideas or expand on them as we go through here. So, of course, the basis for where I was starting some of this research is, okay, well, what happens to their health status and their health behavior? So, use of healthcare system after they arrive in Canada. And so this leads into this idea of the healthy immigrant effects. And what we see, and this is very sort of high level, on average, when immigrants arrive into the country, these recent immigrants are more likely to rank their health higher than the Canadian-born population. So this is the healthy immigrant effect, so whereby the health status of immigrants when they arrive in the country is comparatively high compared to the native-born population, but then declines and converges towards that of the native-born. So coming in at a comparatively high level, and then within a relatively short period of time, that health status declines and converges towards that of the Canadian-born population. Okay? So we see this idea of the healthy immigrant effect not just here in Canada, we see it in the US, we see it in Europe, we see it in Australia. And it's also observed across a variety of different indicators. So one of the most common ones, because it's readily available, is just this idea of self-assessed health. So if you're familiar with that question, it's asking the respondent, how do you rank your health on a 5-point scale? Is it excellent, very good, good, fair, or poor? If you look that up in the literature, there's a huge debate and discussion about how good that is. Is it a reliable indicator of health status for somebody that's born here in Canada, for different ethnicities, immigrant status, by age, because we tend to see that there's this comparison in terms of health status relative to your peers. So, we might be saying, yes, our health is very good here, and the 90-year-old grandmother living in a retirement home is also saying her health is very good, because she's comparing it relative to her peers and not to us or younger populations, for example. So there is certainly some discussion around the relevance of self-assessed health. But this idea of healthy immigrant effect is seen with things like the HUI, so Health Utility Index Mark III, somewhat more objective in that it's looking at different health outcomes, hearing, vision, mobility, for example. We see healthy immigrant in terms of chronic conditions, disabilities, mental health. So again, regardless of the indicator, if it's a chronic condition, they would arrive in the country with fewer chronic conditions, or less disability, and then a convergence towards the Canadian population, or fewer mental health problems, and then a convergence towards the Canadian population. Part of that might be a voice. So finding after arrival, they've acculturated, become familiar and comfortable with the environment, and therefore have the voice in order to speak out about their concerns. They're no longer fearful of maybe losing their status within the country, and that we've certainly observed or heard about those sorts of situations. Those declines in health are generally observed about 5 to 10 years after arrival, and that in part is just a statistical artifact in that this is based on nationally represented data, or this idea of the immigrant health effect is often seen in nationally represented data. StatsCan asking how long somebody's been in the country, and they're gauging it 5 years, 10 years, 15, and so on. So oftentimes in the surveys that we end up working with, it's a 5 or 10-year window measuring how long they've been in the country. Okay, so that's why I say it's partly statistical. But if we go to another data set here, longitudinal survey of immigrants to Canada, we can see those declines in health within as few as 2 years post-arrival, and some fairly dramatic declines. It does differ by, or we see differences by origin and visible minority status, and refugees, not surprising, seem to see this or experience the greatest declines in overall health, again across a range of measures within a very short window. What about healthcare utilization? Well, again, there's some discussion within the literature around this. immigrants tend to receive poor care, so if you're looking at sort of the quality aspect of it, they tend to receive, or document that they receive poor care. And then the literature, again, discussion and debate here, some suggest that there's a similar use pattern in terms of actual healthcare facilities, and this would be measured by, say, visits to the doctor, visits to the ER, or nights spent in a hospital. So some fairly sort of aggregate, again, high-level type of measures of use. With the literature saying, yeah, fairly sort of similar use patterns between native-born Canadians and immigrants. But if we take a look at that longitudinally, so remember that this idea of the healthy immigrant effect, we're seeing declines in health status over a relatively short period of time. If you have declines in health status, then you should be saying, well, there's an increased need for health care. If you have increased need for health care, you should then, by default, see an increase in terms of the use of the healthcare system, and we don't see that. Okay? So are there unmet needs then within the immigrant population? We're not seeing that increased need, or we're not seeing the increased use despite the appearance of increased need. Again, visible minorities are at greater risk in terms of, or lower use of healthcare facilities, and certainly we see more limited use of preventative healthcare services amongst new Canadians. So less familiar with mammogram screening, for example, prostate testing, and so on. Less familiarity there. Okay, so if we have this declining health status and greater need, is that appropriate? No, not really. So what are some of the barriers to care that the literature has talked about? Well, we certainly see language as a barrier to care. Kevin Potty at the University of Ottawa has talked about this considerably, around the role of language difficulties from a individual meeting perspective, so meeting with a healthcare provider and the ability to talk with that client. Over time, in terms of follow-up, scheduling follow-up appointments or tracking health over the long term. But of course, not just the healthcare provider, but even the front desk staff, the receptionist, for example, and their ability to communicate with immigrants. Certainly questions or barriers to use around, that are defined by social and cultural aspects, knowledge of the system and how it works, transportation. Transportation becomes a cost that individuals must bear in order to get to see their doctor, maybe by paying bus fare or parking fees and so on. And for families or individuals that are already low income potentially, that's a cost foregone, or they're leaving work for that. So we do see people talking about transportation as being a barrier. Even something as simple as getting on the bus and asking the driver, where am I going, or how do I get from A to B, becomes a barrier there. Insurance, more so a problem for refugees. We used to have the interim federal health care program under the federal government. That was disappeared approximately 2 years ago now. So rather than having a health care program, even though it was insufficient, difficult to use, difficult to understand, there was something there. Now there's really nothing, so refugees, for example, are showing up at clinics, at hospitals, and presenting there for their healthcare needs. So the burden of cost has been transferred to the hospitals, for example. And then mental health issues as well. So there's issues around sense of belonging, integration into the community, and oftentimes some limited healthcare services around mental health. Okay, just to give you a sense, I'm going to take this down to within the older population in a moment. But this was based upon the National Population Health Survey across a series of different cycles here. So running from 94 to 95 through 2000, 2001. And then capturing here just when they arrived. Again, there's differences or a lot of discussion within the literature around, okay, it's the idea of the quality or the cohort of arrivals. When they entered the country, entering that period reflecting different origins, different immigration policies, different changes in terms of immigration policy, in terms of how or who is favored within that policy. So pulling it apart by cohort is certainly important. And we're capturing then the percent that report excellent or very good health. So just on that self-assessed health scale. I'll just draw your attention here to those who arrived between 90 and 94, that at about that time of arrival, or towards the, the tail end there, 94, 95, nearly 62% were saying their health was excellent or very good. 6 years later, 2000, 2001, about 48.5%. So you're seeing that very quick or rapid decline in terms of health status. Those who have been here longer, so of course are on average, they're going to be older, and there's, in comparison to that earlier cohort, there's a somewhat smaller proportion that is reporting excellent or very good, and it certainly declines to 47%, so a 10 percentage point difference. But that rate of decline is not the same between those most recent arrivals and those who arrived earlier. And then in comparison to the native born, again, declines here from about 65% to about 59%. So with aging, as they move across these years, they're aging, and a smaller proportion are reporting excellent or very good health. But that decline in terms of that proportion is much less than what we see amongst those most recent arrivals. You can go on, or we've gone on, we pulled that apart in terms of gender and greater controls for age, for example, so that we're comparing and we see those same sorts of declines. What about in the healthy immigrant, or healthy immigrant effect amongst the older population? So what I'll show you here is drawn from the Canadian Community Health Survey 2000-2001, and it's aged 55 and over. And actually, I'm going to, spoiler alert here, you're not going to see a lot in terms of that sort of real decline or that idea of the healthy immigrant effect. So for example, we've got a variety of different indicators here. So just over on the left-hand side here, self-assessed health. Healthy, this is going to be very good and excellent. So overall, immigrants, 73.4% at the time, aged 55 and over, are saying their health is excellent or very good. Native born, 76%, and there's no statistical difference. This is the proportion saying healthy. There is a difference here, or the proportion that rank their health as excellent. There's a difference, statistical difference there. Not huge though. Chronic conditions, no difference between immigrants and native born. The number of chronic conditions, no statistical difference. HUE3, no statistical difference. The mean value, or sorry, that's HUE3, the percent that's reporting 1, or what is essentially excellent health. They've scored perfectly on all the different dimensions of a health scale. HUE3, again, no statistical difference between immigrants and native born. We see some differences in terms of males and females over that. So at least here, this picture, we're not seeing that, but the caveat is that this isn't longitudinal. It's a cross-sectional picture of the population, particular point in time. We're not seeing how that would evolve over a period of time. Pull that apart just a little bit more here, just a few ideas. So again, a few different health indicators, now pulling it apart further by age. Again, we're still not going to see the idea of the healthy immigrant effect here, but we're seeing that change by age. So the proportion reporting excellent health, about 20% for those aged 55 to 64, 13% in native born saying are aged 65 to 74, and 8.5. So of course, a declining proportion with increasing age. We see that echoed here in the immigrant population, and there is some statistical difference. So immigrants are slightly more likely to actually indicate that their health is excellent as compared to the native born. Chronic conditions, increasing proportion reporting chronic conditions with increasing age. The number of chronic conditions increases over time. And then that average HUE3, that's declining. So moving away from one indicating decreasing health. Again, not capturing this idea of the healthy immigrant effect, but it's a cross-sectional analysis here. Where we've been able to, I didn't have it in a nice chart form, but we do see that decline in health by immigrant status over a period of time, or amongst the older population. Okay. So, transition into disability. So we've certainly, at least the literature suggests that we see this idea of a healthy immigrant effect also measured in terms of disability within the immigrant population. But when turning to the literature, so it says that, but then you turn to the literature and you start looking for the literature associated with disability in the immigrant population. There's actually not a lot there. There's some work by StatsCan, for example, that's reporting overall rates and prevalence, discussion around caregivers and so on. Certainly nothing that really speaks to disability within the immigrant population, or very little associated with that. So, beginning questions, okay, well, are prevalence rates higher or lower or, the same amongst immigrants as compared to non-immigrants after controlling for age and sex? Are the types and prevalence of particular disabilities similar or different between immigrants and non-immigrants? And how does severity of disability compare across immigrants and non-immigrants? So this is just, it's a very sort of preliminary first cut analysis of disability that we've only just started working here, and there's a lot of questions that still need to be looked at, including roles around caregivers, who's providing care, is there a predominance amongst family members versus paid care, and so on within the immigrant population, what's happening. So just to sort of set the stage here, okay, well, what is disability? The data files that we're working with here come from StatsCan, and Statistics Canada is using this WHO definition of disability as any restriction or lack resulting from an impairment of ability to perform an activity in the manner or within the range considered normal for a human being. So of course we see that disability prevalence increases with age, and individuals with long-term disabilities are more likely to be female, older, unmarried, childless, in fair poor health, and have less than a high school education. So that's just turning to the existing literature. Overall, these are sort of the factors, the correlates that we see. Where are you going, if you're looking at a population, where is that disability going to be more likely to be observed? So we're getting this evidence from Statistics Canada's 2006 Participation and Activity Limitation Survey, or PALS. And that PALS consists of a population that answered yes to a question on activity limitation in the 2006 census. Of course, 2011 census, who knows, sort of what is going on there. The individuals that were pre-screened in the census and coming into the PALS were then screened again, just to make sure that that activity limitation that they were talking about or reported in the census is still present at the time of the PALS, in case there's a short-term disability that they were reporting on in the census, and then it's gone, has resolved itself by the time the PALS survey was completed. Okay? So if you're interested in the statistical part, we've got about 39,000 adults aged 15 and over, representing a weighted population of 2.4 million within the file. So everybody in that file is reporting that they had difficulties with activities of daily living, so preparing meals, housework, personal care, mobility, or whatever, or that a physical or mental problem reduced the kind and the amount of activities that they could engage in. Okay, so it's a file or a data file that is focused on disability, and then there's an equivalent data file that represents the broader Canadian, or the Canadian population, that does not report a disability. So it's again drawn from the 2006 census. So that allows us to create these rates. So really pretty much what I'm talking about here, just some descriptive analyses, again, high level, early results in terms of prevalence rates, so total disability, severity of disability, and then looking at particular types of disability within the immigrant population. And then we've started to do some modeling here to look at the correlates of disability, and I'll run through each of these in turn. But we have a model that's just looking at the correlates, are you disabled or not? And then within the immigrant population specifically, and then also looking at the covariates associated with severity here. Okay, so in terms of some of the results, so this is looking at total disability, and you're going to see a lot of these. So that, of course, get the clicker right here. Of course, we're just restricting that to those people who are 40 and over, 5-year age cohorts out to 80 and over, disaggregated by immigrant status and by sex. So here, for example, male immigrants are in this light or this blue line, Canadian-born males in the purple, female immigrants in the green, and female Canadian-born in the purple here. So, long story short, not really a huge difference in terms of overall disability between males, females, immigrants, non-immigrants. We certainly see that increasing prevalence by age, which we would expect, of course. If anything, what we'll see as we take a look at a series of these is that male immigrants are often sort of on the lower side here. It's not 100% consistent, but oftentimes sort of on the lower side. And female immigrants will sort of be at the top side. So almost this envelope between female immigrants and male immigrants. Again, not perfect, but if you're looking for a generalization, that's where it's going to be. And then Canadian-born males and females somewhere in the middle, with some dances around specific age groups here. So again, not a huge amount of difference in terms of total disability, but certainly males towards reporting some lower prevalence here. So this is pulling it apart by the severity. So the PALS data file then does a calculation, or StatsCan more specifically does a calculation in terms of the severity of that disability. And this is capturing two different types here. So these are all males, and males with a mild or moderate disability, and then a severe or very severe. So the blue here, males with that mild, moderate, and then the purple, maroon here, male immigrants, severe, very severe. Green, male, native-born, mild, moderate, and purple, male, Canadian-born, severe, very severe. So what are we seeing? There's really sort of a separation here, especially as you start or get into the age groups between about 60 to 64 and up to around 80 and just before 80. So here's a very severe group here, mild and moderate. Okay, so that there is that sort of separation between the two groups. So in other words, greater proportion are reporting a mild or moderate disability. That changes amongst the very oldest cohort, where we see near equivalent levels between mild and moderate, or severe and very severe with age. Female severity, very sort of similar, not quite the same gap here, but again, that amongst both immigrants and the Canadian-born, that mild, moderate tend to be greater in the sort of middle, older age groups, and severity running lower and then spiking towards the end of the cohorts. Mobility prevalence, okay, so just in terms of disability by mobility. Again, not consistent, but here's the males, male immigrants at the bottom, female immigrants at the top, same pattern. You're going to see that again and again, of course, just increasing disability by type with age. Agility, males at the bottom, or male immigrants towards the bottom, female immigrants towards the top, and by agility, increasing with age. Hearing, same thing. Pretty much, well, no, males actually end up here more towards the middle, and females towards the bottom. I'm not sure what that says about our respective hearing abilities at all, and I won't comment either around that. And speaking prevalence rates. So again, a bit of a reversal. Males here, we couldn't pull it apart. Fewer numbers here, so we couldn't disaggregate in quite the same way. We had to leave it at male, female, immigrant, non-immigrant in this case. So it's a little bit different here. But because it's relatively low rates across the age cohorts, that are reporting a speaking disability. And then finally, seeing. So any sort of vision type of impairment here, and what we're seeing with that. Again, male immigrants tend to sort of be, in this case, towards the middle. Females more on top there a little bit, and native-born towards that middle pack as well. Not a huge amount of variation then. We do see some sort of separation in terms of immigrant, non-immigrant status, females, males, and from a statistical standpoint, there are certainly cases where some groups are significantly different than others, say male immigrants having a lower prevalence rate than females, but not consistent even within a particular disability. As you move across the different age cohorts and work out that statistical significance, it's not consistent across the series. So it sort of moves in and out of statistical difference. You're not getting sort of a nice, neat overall picture to say, oh, well, for this disability X, male immigrants are much less likely, or statistically significant less likely to report that disability as compared to female immigrants. Can't do that. Can't say that. There is just that sort of lack of overall or consistent message. Okay, so this is getting into some of this preliminary modeling. So this is just looking at disabled, yes or no, immigrants and non-immigrants included here. So these are the odds ratio for those that are reporting a disability, or for immigrants reporting a disability. So immigrants less likely from a statistical point of view, and this is all disabilities, I should add. We haven't pulled it apart by the type of disability, it's all disabilities. So overall, immigrants are less likely to report disability status. Here's our age cohorts, and it's relative to the youngest age cohort that we were working with, 40 to 44-year-olds. So older age cohorts are more likely to report a disability. Again, immigrants, this is entire population then. And with increasing age, that odds ratio continues to increase, that there is more and more disability being reported with increasing age. This one is interesting. We're still trying to figure this out. Is it actually there or not? Females. So if you remember when I first started talking about disability, I said, well, if you turn to the literature, it's saying that females are typically more likely to report a disability. Here we're getting the opposite. Females less likely to report a disability, and not sure what's going on there at this point in time. Marital status, so marriage as a protector. Individuals who are married are less likely to report a disability as compared to those who are widowed or separated, divorced, and also those who are single or never married. We're also somewhat less likely and still statistically significant to report or to not report a disability. Education has an effect, so it has a moderating effect in comparison to the poorest educated, those with less than high school. Again, there's sort of that sort of gradient. Higher degree levels or higher education, less likely to report. Lower education levels, more likely to report a disability. Awkward wording, not low income, so in other words, high income status, less likely to report a disability, so again, consistent. And then employment. Those who are working, whether it's full-time or part-time, are less likely to report a disability. Pulling it apart, this is just immigrants only. We see many of the same sort of patterns here. So that increasing prevalence associated with age, for example, in comparison to that youngest cohort. Females, it's still coming out as less than that odds ratio, less than 1. At least here, it's statistically insignificant. Marital status is protective. Level of education as being protective. Income, that falls out. It's not statistically significant. And then working status, again, if you're working, whether it's full or part-time, being protective in terms of less likely to report a disability. And then finally, this overall severity, severe, very severe versus mild or moderate. So echoing some of the graphs that I showed you. Immigrants here, so amongst those that are reporting a disability, immigrants are more likely to report that it's severe or very severe. I'm, in part, curious about sort of how these concepts of mild, moderate, severe, very severe, although they're a statistical creation, I think there's a lot that's sort of loaded into the terminology that's being used. So if you were able to unpack what those measures actually are capturing, that there may be differences in terms of how people are interpreting the severity, how they view the severity of their disability. And in part, I have a graduate student working with me right now, and she's looking at vision impairment. And one of the questions that she'll be asking her respondents is how they view that visual impairment relative to their immigrant cohort, or to other immigrants and to their own sort of cultural background. What role does that play? And that, amongst other questions, will start to give us some insight into, okay, well, what does this actually mean here, and how are different groups seeing these ideas of disability? It's not a uniform, despite where who is coming from, that early definition I put up there, where Stats Canada is drawing that from. It's not a universal sort of platform in terms of this is what disability is, end of story, end of discussion. Females, so amongst those females that are reporting disability, more likely to report very severe or very severe. Narrow status still protective, so if you're married, you're less likely to report severe or very severe. Education, same sort of pattern, less likely to report severe or very severe with higher levels of education. High income, less likely to report severe or very severe. And working full or part-time, again, less likely to report severe or very severe, which also then, of course, reflects their abilities, that they are less likely to be working if there was a severe disability. Okay, so just a few thoughts to wrap up here. So immigrants less likely to report disability than the native-born, but when they do, immigrants are more likely to report severe or very severe disability. Females typically have higher prevalence rates, although that logistic analysis, the multivariate analysis, seems to suggest otherwise, but I'm going to put that as a big question mark because it's not consistent with what we see elsewhere, and we're still sort of exploring what that actually means or how robust it is. Okay, so where do we go next? Taking a look at some of the longitudinal changes in disability, so tracking those cohorts over time. Quite curious here to see whether or not the burden of disability differs between immigrants and non-immigrants after controlling for prevalence. So we can see some hints of differences in prevalence. So we can see some hints of day-to-day life, employment, and so on. Try to unpack that some. And then also looking at issues around care, the source, the type, the amount of care received by individuals, and are some groups, immigrants, non-immigrants, more or less penalized, or receive more or less in terms of particular source or type of care from or within the system. So I'll leave it at that. Thanks to CIHR who funded some of this, some of the work at the IEC and the colleagues there, and my RA, Dylan Simone. So I'll open it up for questions at this point. Thanks.
Thank you.